Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Shamita Shah. She's a gastroenterologist, and today's Kevin MD article is How Doctors Can Help Inflammatory Bowel Disease Patients Manage Symptoms Between Visits. Shamita, welcome to the show.
Well, thanks for having me. I'm very excited to be here today, and I'm looking forward to talking to you a little bit more about the article that I wrote and also how we can enhance IBD care in general.
All right. So before we do that, just briefly share your story and journey.
Yeah, so my journey, I've been doing inflammatory bowel disease as a specialist for Crohn's and colitis for approximately 15 to 17 years now. I started with this. I have an interesting story, mainly because it was my father who kind of has driven a lot of my passion. He was unfortunately mismanaged and had this disease and had complications and stuff and passed away. And so a lot of what drives me in my career is really to see if we can deliver the best care we can to these patients so that they don't have poor outcomes.
All right. So tell us about the article for those who didn't get a chance to read it. It's titled How Doctors Can Help Inflammatory Bowel Disease Patients Manage Symptoms Between Visits.
Yeah. And just to add to that, I've learned a lot through my journey with my career also, Kevin. And I think that says that, I was a clinical director of IBD on the West Coast at Stanford for a while, and now I'm the clinical director here at Ochsner. And I think both of those have made me open my eyes to how to deliver care in different areas of the country. And
Hmm.
also I've learned a lot through that. The article primarily, is just focusing on that there's a growing number of patients with this disease, and it's a chronic disease. And as you know, chronic diseases have a lot of disease burden. We have these patients have diarrhea, rectal bleeding, they're fatigued, they have weight loss. And so, we get a very focused time point when we see them in the clinic, but
Hmm.
what happens to them between those visits?
Yeah.
And how do we engage the patient to track their symptoms, and what kind of stuff can we do to help them with that? Whether it's now there's more and more technology to help patients with that, whether we're talking about computer interfaced IBD monitoring platforms. There's also, wearable technology that's been shown to be helpful to track flare-ups for these patients between visits. Patients forget what happened in the last 6 months, the last 12 months between their visits. And so there's ways for them to document kind of what's happened to them in that time frame and when to escalate, the need to see a physician. The other thing is diet plays a big role in
Hmm.
inflammatory bowel disease, and how do these patients track their diets, and creating food diaries and that sort of thing. And that's where also technology can be very helpful. We have checklist to allow for providing a checklist for patient accountability. Did you get your vaccines? We use a lot of medications that can suppress their immune system, and so with that, getting your vaccines to prevent infections and stuff is going to be very important, especially those seasonal vaccines and stuff. So, I think this article is just kind of highlighting that we have to think of IBD care in a different way now. Times have changed. Times have changed in all fields, but in the last 10 years, the number of medications and advanced therapies we have make us have to change, and then growing number of
Hmm.
patients really.
So, in general, as a gastroenterologist, how often do you see patients with chronic symptoms from IBD? And what do you do with this trove of information when patients come to you with these diaries, whether it's remote monitoring? So, give us a scenario, a story, or an example of how you would use this data during a visit.
Yeah. So we're working on several things right now in our clinic right now is how to monitor them between visits. And one of the things is that if they come in with symptoms, those patients who are having active symptoms and not doing well, they're going to be seen more often.
Okay.
Those patients that are in deep remission, doing well, and they're adherent to their medications, they're communicative with the care team when something's not right, those patients may be seen less often. But within that, I think that, we're using some EHR platforms, including, using our EHR in ways that we're kind of utilizing our nurses in a different way. They have patient panels that we're going to be building, and so that they can check in with the patient. We have clinic-based pharmacists that help as extenders in my clinic, and that's been very helpful to kind of monitor them in between their visits. But there's also other platforms out there. And as I mentioned, there's wearable technology that we're looking at, but also there's computer-based platforms like Sonar MD is one of them. There's some other ones out there as well. So again, I think it's important to kind of identify which patients go down which track or
Mhm.
which, how you manage each patient and depending on their disease activity and other social factors as well.
And what specific symptoms or patient reports are you looking for to perhaps bring them in for more acute treatment?
Yeah, mainly abdominal pain, diarrhea, weight loss, fevers, those sort of things. Those are probably the most common. Some more subtle things are like bloating or something's changed about or they're more tired all of a sudden, those sort of things, but generally GI symptoms.
You mentioned in your article that there are studies that show reduced emergency department visits for people who monitor their symptoms, right?
Absolutely. So, for example, that computer-based platform and some of the wearable technology, they're really at the forefront of technology, and they have been, they've shown that if you can early monitor these symptoms, then you can prevent ER visits, hospitalizations, and decrease not just cost of care, but really improve the patient's quality of life, and so that they can go to work because there's a lot of missed work, missed school. This disease population, it does affect people at a younger age often when they're trying 18 to 35-year-olds 50-year-olds, and so by controlling their disease they have better quality of life really and can go on with their life really.
You mentioned earlier that diet plays a large role in terms of potential triggers for IBD. So talk more about that. What are some things that patients can do themselves to potentially reduce the incidence of flare-ups?
Absolutely. So there's a DINE study, which is one of the studies that were done that actually was a randomized control trial between Mediterranean diet, specific carbohydrate diet. But the premise of most of these diets are, it's really important. Some very simple things that patients can do is decreasing the amount of sugar that you're eating, less processed foods. Mediterranean diet seems to have a lot of data and a lot of evidence that can be helpful, not just for inflammatory bowel disease, but also cardiac disease, as we know. So these are some small things, but keeping a food diary so that if you're not feeling well after a certain food, then maybe reevaluate that and kind of bring that up to your physician when you go to their visit so that they can help guide.
And you mentioned the importance of vaccines because a lot of these patients sometimes are on immunomodulator therapy. So give us a sense of any additional vaccines, or is it simply sticking with the typical adult recommendations? So give us a sample of the vaccine schedule.
Sure. So beyond the regular vaccine schedule, when somebody has a low immune system from medication that we're giving, whether you're a transplant patient or an inflammatory bowel disease patient, it is recommended that you get a pneumonia vaccine, shingles vaccine before the age that it's indicated. We recommend the RSV vaccine, flu, COVID, tetanus, just regular schedule. But we also are very particular about, HPV and making sure we discuss HPV vaccinations with our patients as well. One of the things that I want to emphasize is there's no live vaccines. So if you're on immunosuppression, you cannot get any live vaccines. The other thing is that it's important to vaccinate them before they get immunosuppressed if you have that opportunity, because they mount a much better response to the vaccine if you do it before they're immunosuppressed.
So we've been talking about a menu of options that patients can use to monitor their own symptoms. So sometimes the amount of choices can be overwhelming. So if we have a newly diagnosed patient with inflammatory bowel disease, what do you typically recommend to start off with in terms of monitoring some of their symptoms?
Yeah. So I think symptoms wise, you're just you want to see where is your baseline. And then when you're well and you're in remission, what changed, right? And mostly, many patients, it's abdominal pain and diarrhea.
Mhm.
I think the most important thing is to ask a lot of questions. Patients need to ask questions of their providers. They need to know what their options are because there's so many more options. Even in the last 5 years, we've doubled the number of drugs that we have available. So it's important to know that you have options and it's not just whatever was available 20 years ago. And we have to move with time and offer patients that less risky medicines that are more effective. And that's what we've done over the years. I think the other thing is that patients really need to, understand where their disease is in the intestine and the type of disease they have. So whether they have any complications or outside the bowel manifestations of their inflammatory bowel disease. As we know, inflammatory bowel disease can affect the joints, the skin, the eyes, that sort of thing. So it's important to understand your disease phenotype.
So sometimes as a primary care physician, I see patients, of course, in between visits with a gastroenterologist. Now, are there any specific questions that I should be asking or any symptoms I should be looking out for when I see these patients in a routine visit in between their GI appointments?
I think there's three aspects to this. So one thing you can do is asking about symptoms like how many bowel movements, have you noticed any changes in your bowel habits? And it could be very subtle changes in the consistency or the frequency, waking up in the middle of the night with any bowel movements, any blood in your stool, those sort of questions, abdominal pain, where is it? And is it associated with their IBD or not? The other thing as a primary care physician that you can do is biochemical monitoring. And what I
Mm.
mean by that is looking for anemia when it doesn't make sense. Iron deficiency anemia may be an indicator of active disease. Inflammatory markers, CRPs, we use a lot of, and obviously if it's specific for the disease and not something else. And then the other thing is a stool calprotectin test, which is a stool biomarker that is more specific for inflammation of the gut. And that's a very good way to closely monitor the disease non-invasively without a colonoscopy. And then the cancer and the IBD health maintenance sort of stuff, pap smears, mammograms, skin exams yearly, because patients with IBD are at higher risk for skin cancer as well. And then the vaccines, of course, that we already talked about.
So you mentioned you work for Ochsner as well as in Stanford, major academic medical centers. So I was talking to a specialist yesterday about sometimes about the geographic disparity, right? Because a lot of the things that we talk about and we're talking about today, like remote patient monitoring, they're only available to large urban centers, academic medical centers. What about those patients kind of in rural settings where seeing a gastroenterologist may take, a couple hours drive and they may not have those technologies available? So talk a little bit about the geographic disparities that sometimes you see when it comes to monitoring IBD patients.
So I'm really glad you asked that question because I think over my career, that's one thing I didn't understand fully in the beginning of my career, and I understand much better now is, I did my training in Chicago, University of Chicago, and that was a very different, the Midwest population versus the West Coast versus the South population. And many people come from over the Gulf South over to Ochsner to be seen. But I think patients' education, their diet, how they function in their community, their education. You have to factor all of those things in because that determines what medicine you're going to give them, believe it or not, or how you're going to treat them. And my patient population in California and Palo Alto is very different than New Orleans, Louisiana. What their priorities in life are different and what their availability to access to care, as you said. So, this is where I think technology has helped us a lot because we're able to deliver care virtually, audio visits, video visits. And that's one of the best things that happened, in my opinion, during COVID is that we're able to deliver care to a greater number of patients. It made us, my group, actually, we got our licenses from all the way from Louisiana all the way to Florida. So we have license in Mississippi, Alabama, Louisiana. And so we've been able to use that digital platform to deliver care to these rural areas.
So you mentioned sometimes the patient population can really affect sometimes even the medications that you prescribe, West Coast versus the South. What would be an example of that?
Yeah, so I mean, I think what I'm kind of talking about is not just, what their insurance is and what the cost of care is, but also what their beliefs are and what risk they're willing to accept. And so I think that on the West Coast, for example, I definitely saw more patients wanting to do more alternative complementary medicine. And sometimes it was definitely evidence-based and it made sense, and sometimes it didn't,
Mhm.
and here, some patients don't even have access to care, right? We see uninsured patients on call or something, and you're like, how do I get them their care? I've done things like where they didn't have care and we just did phone calls until they got Medicaid, things like that. So it's it's interesting to see how you have to change your practice as a physician based on where you are and what your patient population is. And I don't think people understand that. So what works over there doesn't work over here, right? Always.
So let's take a step back. In general, what's coming on the horizon when it comes to managing inflammatory bowel disease patients? Anything that we have to look forward to?
Yes, a lot. I think we have way more advanced therapies now available, which makes it a better playing field for patients. We have so many options and so many low risk options as well and effective options. So that's exciting because when I trained, there was only a few drugs and now there's so many more. But with that, I think that, the other things that are more exciting is the technology. And that's what
Mhm.
my article highlights, just coming back to that, is that how do we embrace this technology to deliver care to a greater number of patients in a different way? And if we don't rethink how we do things, we all know that there's a huge shortage of doctors, up to like 125,000 they're predicting in 2030. GI being one of the biggest subspecialties that are going to be deficient. So how do we use technology to deliver care better and more effectively to a greater number of patients?
We're talking to Shamita Shah. She's a gastroenterologist, and today's Kevin MD article is How Doctors Can Help Inflammatory Bowel Disease Patients Manage Symptoms Between Visits. Let's end with some take-home messages that you want to leave with the Kevin MD audience.
A couple lessons, just for the clinical audience, is that for those of you who are already thinking about revamping how you approach chronic disease care, it's worthwhile to engage with your own organizational leadership to discuss your vision and also have them help you break down the walls of the traditional ways of delivering quality care in patients. And I think the take home message also is that we know this is a chronic disease. It's difficult to manage ulcerative colitis and Crohn's disease, and it affects patients in so many different ways that we can help our patients by focusing on patient education and giving them tools to help manage their disease in between appointments. And as a group, we really need to utilize technology to help to deliver that quality care to more patients who need it.
Shamita, thank you so much for sharing your perspective and insight, and thanks again for coming on the show.
Thank you so much for having me.